Thank you for joining us for this 11 o'clock Senate Committee, Special Committee on COVID-19. Our Chair, Donovan Dela Cruz, will be in shortly. We have with us myself, Michelle Kidani, Senator Sharon Moriwaki, Senator Donna Mercado Kim, Senator Kurt Favela, and joining us online is Senator Jared Kiolololi. Jared, can you hear me?
Yes, I can. Thank you.
Thank you, Jared. So we'll start today's hearing with Lieutenant Governor Josh Green.
Thank you. Thank you, Chair. Thank you, senators and friends. Please interrupt me anywhere along the way. I try to give you as much information as I can and open to absolutely any questions.
We never are shy about interrupting.
Good, I know. Yes. So aloha, everyone. I do appreciate being here. I'm going to dive right in. COVID-19, coronavirus disease, that's the pneumonia 2019. First, let's talk about the curve predictions. So here you can see over my left shoulder the data that we're getting up to the minute, if not hour, to describe exactly what the crisis is right now. You can see back here on the 26th of March, that is when the order came into shelter in place and where our flights were significantly curtailed into the state. We'll talk about that some. I still have concerns that any travelers coming in here at all. I think it's about time to call that madness and stop that totally. I know there are some challenges, but we should do that. So as you can see, this is what the curve has looked like. When we first drew the red lines, those red dots, that was our perspective curve if we have about 85 to 90% compliance with both the stay at home, the shelter in place, and limited abuse or minimal abuse of people out in the public, not wearing a mask. This is before masks were being used very widely, or standing in lines too close to one another, not social distancing. If you look at the curve, you can see that we've typically had around 20 to 25, on a couple occasions 30 cases, a couple occasions less than 20 per day. Today, we have 25 new cases, 6 of which are in Maui, and we'll talk about that. That makes the Maui cluster 15, and it's something important to talk about at Maui Memorial Hospital. So the curve has been flattening. It is not clear that we are out of the woods by any stretch of the imagination, but we have not seen a geometric spike or an exponential spike based on our testing. We have a lot to share on this slide. We've had 15,000 tests done now, 15,149 tests as of a couple hours ago. 2.8% or so have been positive. We've had testing in all of the regions, and I'm going to get to that in a moment because I'm very focused on making sure that people understand that we're not just testing, obviously, on Oahu. Some important other things here. On the 2nd, we were at 1 week for the home quarantine, and we're now rapidly approaching the 2-week home quarantine. This is a very important number because 2 weeks in home quarantine and 2 weeks being the extent of what we feel is the kind of the all clear on an exposure and then not being infectious. It's very important because most people have been at home. There have been certainly some people that have flaunted their freedom and not followed. We have testing capacity of 1,500 people per day in state. That includes DLS, clinical labs, our state lab, Tripler. And we are producing some plans for both expansion of our beds if we need it. I'm about to talk more about that. And significant expansion of services in the state, building out a hospital with support of the Army Corps of Engineers and FEMA. So all these plans are going into place. Now let's talk about the exact numbers in our state. So here we are, April 8th. Total hospital beds in Hawaii, 2,773. These numbers fluctuate by 10 or 20 occasionally if an ward is opened or closed, depending. We could increase that immediately by 457 if we had a big surge. The goal, of course, is to keep the surge flat. Very slow growth of numbers, and we can share all of these with you, obviously, because if we keep it flat, we never get a spike that exceeds our intensive care unit capacity and our ventilator capacity. That 457 increase, a lot of that is very quick. They can double up rooms. They can take the surgical theaters where we're not doing any elective surgeries and turn them into intensive care unit rooms right away with ventilators. Today, as of this morning, we are using, of our 2,773 beds in the state, we're using 1,304 beds. That's 47% of our beds are filled. We're coming to the end of the flu season, and people are washing much, much more. So we will see a decline in flu overall. 47% is down 1% from yesterday. ICU beds in the state. The number I use is 338. That's the standard number if you count across all of our facilities. You also are counting NICU and PICU beds, neonatal and babies, kids, because you can turn those into adult beds if you have to. Right now, 97 of our 338 statewide ICU beds are occupied. That's one less than yesterday. 28.6%, down 0.4%. So we have capacity there if we had to right away to increase our care for people in the intensive care unit, but not obviously if we had 600 people suddenly in critical condition. We would be in extremely deep trouble. We have 535 ventilators in the state of Hawaii. As of yesterday, we had 83 people on ventilators, and the good news is nobody died yesterday. So it's good news every day that nobody dies, but yet we didn't suddenly have people off the ventilators because they passed away. So we are at 65 ventilators in use out of 535 in the state. That's 12%. So 88% additional capacity of ventilators if we had to put people on ventilators to keep them alive, particularly people with chronic disease, lung disease, or our kupuna. Those are the highest risks. So we are at 12% and 65 being used. And the number of people in the hospital today for COVID-related illness is 59. So I wanted to give you that number because that number of COVID-related illness, 59, that's out of the 1,304 people that are in hospital beds, only 59 are currently hospitalized for COVID-specific disease. Obviously, we've had a total number of, as I said earlier, 410 going up a little bit of total cases, but only 59 of all of them are in the hospital. Some have recovered. 5 of our citizens are deceased over the course of the outbreak. So that's kind of the first blush at what's going on. And I'm going to come back to this as you need. But I prefer to keep this other curve up there because I think it's a little bit more informative overall for the big picture. And I think as we go forward towards April 30th, our hope is we continue to see this flattening trend, although it could change very quickly. A cluster of 50 or 60 people, I'm very worried about what's going on in Maui Memorial Hospital right now, where there's 15 people. 8 of those individuals are connected to the oncology ward, cancer care, people with depleted immune systems. That is, of course, one of the highest risks. Okay, so that's part one. Now, it was mentioned to me that we had interest, as do I, about where we're testing exactly. And so let me go over the lab numbers I have for clinical labs. Keep in mind that clinical labs and DLS are our main 2 laboratories that can do testing for the state of Hawaii, although there's some Kaiser, of course, and some of Tripler. But of the 15,000 tests done, a total of 9,312, so 9/15 of the tests, have been done by clinical labs. And here's the breakdown of the islands. For Oahu, of those 9,000, 5,287 tests have been from on Oahu. 133 tests are still pending, 116 are positive. And it breaks down like this. Of the 9,300, 1,510 of the tests are from Big Island, 165, about 10% of them are still pending, 16 are positive. Kauai for Senate President, 885 total tests have been done by this lab. 50 are pending still, getting the results back, and 16 are positive. And finally, Maui, 1,630 of the 9,300 tests were on Maui. 128 tests remain pending, and 45 individuals were positive. So this, again, is 9/15 of the picture. The other 6,000 are DLS, basically. So you can see that there is some clear spread across the islands. I want to now spend a little bit of time talking about testing, if you don't mind, because this has been contentious, and I feel very strongly about this. We have had guidance, of course, from the feds, right? So they have, in general, told us that you want to test people only who are symptomatic. I find that very, very problematic. So what I feel strongly about in the state of Hawaii, for a couple reasons. One, because we have multi-generational families at a 2 times ratio, many, many more multi-generational families. I feel we must do contact testing. When we have positive people, the Department of Health does their best to contact trace, and I defer to them to talk about their program and how they're doing it, whether they have enough people and so on to contact trace. But as you saw just a couple days ago on Molokai, first one individual at the store was positive, then the person's spouse was positive, then a third person, and just in that small community where everyone was spending close quarter time together, just contact tracing, they had to, it's unusual, they had to actually have Senator English and Rep. DeCoy go and help with that tracing. They may need more support. I leave it to them to ask for whatever they need and how they're going to do it. But the problem with just contact tracing when people are asymptomatic is it leaves this large puka in what we find out. We know a large percentage of people are asymptomatic carriers of the disease. And if they're walking around, they could be spreading. What we must do, and this is borne out in a lot of different countries, if we want to stop this disease, we must contact test. We will have some negative tests, no doubt, and people will have to be informed. You're not necessarily out of the woods, but if we use some of our extra tests, and I'm not saying dive deep that we can't have enough testing for our ICUs, our intensive care spaces, we must contact test, and we are going to do that on Maui today with the crisis that's emerging there. So contact testing is absolutely critical for close contacts, for intimate contacts. I wasn't trying to be too kitschy when I said if they kissed them, test them. I'm just saying in that kind of close quarters, if people have a kid in your bed, if you have your significant other, if you are a firefighter and you're in the bunk next to one another for a 24-hour shift and you're that close, contact test that person. We have enabled what's called the red team for the general, so we can go out and get more testing very quickly because we can do same-day testing. If we get test results or swabs back by 11:30 in the morning, we can get the same-day test here on Oahu. Otherwise, it's one day. We also have these new machines, which you've heard a little bit about, Abbott. Each state received 15 of these machines. Those are the rapid testers. They can test it within 5 minutes. You will get if someone is positive, and you confirm it over the course of 13 minutes that someone's negative. So within 15 minutes, you know, positive or negative. But we have a very limited supply. They only gave us 100, each state, only 120. The kits only do 120 tests total per week. So we will have to get many more kits, and it's still time limiting. There's other testing that we can discuss, such as the antibody testing.
Anybody have questions?
Yeah, I have a question. Lieutenant Governor, I appreciate what you're saying about the testing and how you can do it in 15 minutes. But even though they may test negative at that point in time,
yes,
we know now that 2 hours from now or a day from now, they could be positive.
Right.
Isn't that correct?
Yes.
So for those who have firefighters or police, et cetera, or even the health, the nurses and doctors,
yes,
who have a colleague that they have worked very closely with that has tested positive,
right,
shouldn't the test, if it's negative, shouldn't they go back and test that person again?
Yes.
Within a certain amount of time?
3 days later.
And
yes.
are they doing that?
No.
Who is they?
Whoever tested them the first time.
So is that required of them by Department of Health?
No. Department of Health doesn't even say that.
No, so when, that's what I think we got to ask Department of Health, what are the protocols that they got to...
But Department of Health does not agree that we should be doing that many testing.
Yeah.
Dr. Anderson said that, and so did
right.
Dr. Park. They're the ones that are, we've been pushing more testing, and they're the ones that kept saying, no, it's not going to help because, you can be negative, it's a false negative, people are going to think they're safe, da-da-da. They didn't want to test at the airport, they didn't want to screen, they didn't want to do the 14-day quarantine.
Right.
They didn't want to do any of that.
Wear masks.
And that's it.
Yeah, they didn't want us to wear masks. Well, not they didn't want us, they just didn't feel that it was necessary.
Well, they said it. help.
If I may, I think you should tell them what you want, period.
We have.
Yes, and insist on it. The truth is that there's massive support for contact testing, and then we always will have to keep just enough available. But a couple things to point out. There's 410 people total now gone up to, I guess, 435 today. I haven't put that number right up there. 435 people. Even if you just wanted to contact test everybody from this point for the last 11 days, 12 days, I'm sorry, from 95 to 435, so about 330 people, you could contact test, say, the 6 close contacts to them, and that would just be 300 times 6 people, 1,800. We already have philanthropy that's willing to pay for it, even though we don't need that. We have resources, we have adequate testing. Over a couple days, we could test every single one of their close contacts, and we should. We're going to do that on Maui today. We're going to now go do close contact testing.
I have a question too. So, LG, thank you so much for what you're doing in this testing and trying to get a resolution from Department of Health and what you're doing in terms of the testing and contact testing. So if you do the test, and as we've been told, that you can test them one day and it's 5 days later you might come out positive. Is there a protocol so that you test, but then within that 14-day period, that if the department is doing it or whoever is doing it, that they stay in contact for those 14 days so that they've got some way of tracking, even if you're negative?
A couple things, excellent points and critical things. First of all, I think you should ask, because I don't know the answer, you should ask exactly how many people they have helping them. And if they don't have enough, offer more people. Okay, so offer that first of all. Second of all, we have a large number of people that can help. The nursing, there's a coalition of 375 nurses with the DOE that normally provide nursing for disabled children. They're available, and we've already contacted them. They're already under contract, already being paid even by DOE. So we're training them up. This is all under Jim Ireland and the red team under the general. So there's that. The other thing about it is, let's assume what the real circumstances is with the virus, okay? Normally, the average length of time from exposure to symptoms, the normal time, though it varies, is 5.2 days. But many people are asymptomatic. So let's take, for instance, this cluster of people over at Maui Memorial Hospital. We have the 15. Let's test the 6 to 10 people around them. They're close contacts. Some of them will overlap. They're friends and they work together. Test those 10 times 15. That's 150 people. Some will test positive, and then you will know at that moment to put them into 14-day quarantine at home, and you'll test them after their period of time has passed so that you can get a negative test, they go back to work. For those who test negative, that's fine. They're very unlikely to be very symptomatic. You could assign them to do background work, admin work, whatever your choice is, and you can make that determination. And then, if you choose, you can do it at a 3 or 5 day interval, test them again, because they were close contacts if someone confirmed positive, and they're health workers working with sick people. This is very important. Then finally, once you decide to clear them, you can do it with another negative test. So you have the control.
That process is based where?
There's processes all across the globe.
So where did you get that from, though?
Well,
CDC or?
No, as a physician, after 3 days and 6 days, you know that you've had enough time between the time when they were exposed and positive. And so right now, they don't want to test anybody.
So what I'm trying to get at is, if we can tell the Department of Health, this is a process based on X, can you guys follow that? Because your advice was just tell them what you want. Yeah. But none of us here have that kind of that. So I'm trying to find, where do we source that process so we can tell Department of Health, this is a process you need to follow. This was followed in whatever state, whatever city, whatever country.
We can bring up protocols for we'll find out either Korea or Singapore where they did how many days apart.
Because then if not, they're going to just debate us and does it help us? Yeah. So I mean, if we can at least find source material for those processes.
Okay. Well, I'll work with someone right now to try to get you source material, because the best practices, which is widely supported, are the countries that did well, and that's Singapore, South Korea, and Taiwan. And so then they're doing massive testing, of course, of all contacts. They're going way beyond this. We're not talking about just testing any asymptomatic people. We're talking about just intimate contacts, which already is a compromise, and no one should push back against that. But we'll get you some. We'll get you some guidance.
I mean, I'm not opposed to us being the first in the nation having to do something like this. I think that's good that we lead like the airports, right?
Yes.
But it's good. With Department of Health, I almost find that we have to have some kind of source material to say, look, this process, just adopt it.
Just a protocol, simple protocol.
No, I understand. I agree with that. I understand what you mean. Yeah.
That'll be good.
Okay, any other questions?
Yeah, Josh, Lieutenant Governor, how many of these tests are being done in state and how many are still being sent away?
Perfect question. Okay, so 1,500 per day are done in state in the combination of clinical labs and DLS.
So that's just you calling every single one, or are they calling you, or?
It depends. It could be a hospital. Queens did for clinical labs. They did.
So how do you gather all that?
How do I gather all that data? We go through ESF8. All that data goes to the ESF8 team, which is run by Dr. Hankins, and all the data goes directly through him. So that way, Department of Health and the labs and all the data goes to him. So it's one point of.
Because oftentimes Department of Health has told us, well, we don't know how many tests the private guys are doing.
Yeah, all that goes now organized through Dr. Hankins, and they've actually come up to speed very nicely so that we can streamline the information for you, for General Hara, for whomever needs it.
What is ESFA?
What does ESF stand for? They have 15 ESF. These are these centralized committees underneath the EOC, the Emergency Operating Center.
That's
Hawai'i's structure, right? And so ESF8 happens to be the health one. They have good dashboard they're putting together. They have some actually excellent slides which we can get you and you should request. That's where I get all of this data. We have a meeting every day at 9 a.m. with General Hara, about 8 of us, and all of the key data comes in. So it's all centralized so that we don't have data going all over the place. There's always a small variation depending on if one hospital's late or one lab is still a day behind, but it's
so that's open to the public.
No, it is open, but it would be open to you, though. Absolutely. I do share it by about noon every day. I share the numbers, but they like to do it through the Joint Information Center.
So I thought Dr. who? Hankins.
Dr. Hankins, yes, and we'll share.
He controls the site, or he controls the database.
Yes, exactly.
And that's a private committee.
It's under the general. Yeah, it's a private committee, and he has.
So it's under government.
It's under government. He has different subsets coming to him, like the long-term care subset, the hospital subset, the lab subset. So it's structured so that he can get all the data in a organized way.
So you have 1,500 tested in-state per day. How many out-of-state tests?
Well, they can send more tests. So they can do this many tests and prioritize this many tests so that same day, if they're by 11:30 in the morning, or if, let's say they get it at 4 p.m., the lab will get it to you the next day. So
are they still sending tests outside the state to do?
They are. And those tests now take 4 to 5 days. Though we've all had experiences, it's been much longer. But now it's telescoping towards closer time because we're getting our act together and able to do this. And then there are some same-day tests also that can be done with these quick Abbotts, but they're going to be very few at first. Eventually, a lot more rapid testing will get done. This is really fast. That's, the 15-minute or less test. These ones are the 3-hour tests.
Is the rapid test still the ones that you do in the nasal?
It is, yes. Yeah.
Senator Kidani,
Yes.
have you been working with the University of Hawaii, with Japson or any of the medical school in helping with tests, or can you share any of that?
Yeah. That's a very good question. So actually, Hankins wants to base out of Japson, and he has brought some people from Japson into his team. Some of he I believe, is actually like an adjunct clinical person at Japson, so he's on their faculty. The Dean Hedges is very, well involved or knowledgeable that we're doing this. There has been discussion about bringing extra service and staff if they need help. So the question would be, do you use medical students, do you use other faculty that have doctorates or have some kind of expertise in the epidemiology? And we're using the university some other ways too, not to drift from this answer, but some of the engineering departments are doing some work which could end up being quite helpful. So there is integration. Right now they're housing their facility, I believe, over near with the Hawai'i guys, but they had preferred, because there's a lot of space over at Japson, to do it over there.
So the state lab, though, can only do what did they say, 85?
$250 per week, and if they were driven with a whip, you could get them to $500 maybe a week. But assume $250 a week, so divided by 7, 35 a day. One thing to be clear is the reason we set up some of the standards for like this red team is because there are some needs to get people tested like instantly. For instance, the crane worker at the, of which there are only 4 crane workers here at the harbors. If they get a fever or a cold or something, rather than have them out for 14 days, test them and get the rapid test done. And so we save some of those tests, and that lab, the state lab, can always do it same day, that number.
So Josh, how much is it costing us with the private labs? Is there a cost to that and results?
Insurance is paying for that, so if people are insured, I assume they're paying. I have no idea, I have no idea what they're paying in general. My understanding was it was about $120 a test from the state. I assume it's something similar from the private sector when they run these tests. These other labs, these rapid tests, I don't know what we're charging at all. We haven't done any of them yet. It should be a relatively small number compared to the catastrophic numbers of loss from economic activity. But over the time, let's say over time we do 20,000 tests or 50,000 tests. Right now, all of the insurers are covering it, and they're not asking for any co-pays. And the part that we may end up paying is Medicaid for those who end up on.
But that cost is paid by somebody.
Yeah,
right?
the cost will definitely occur,
Right.
and I have a feeling that they're going to sort this out over time because, well, right now it's been 15,000 tests.
So the impact to the state at some point.
Could be. I mean, yeah, let's say right now, remember, a quarter of our people are on Medicaid, so that would be a quarter of 15,000 would be just on about 4,000 people, and if it's about $100, $400,000 of testing for Medicaid individuals, some such number. We're going to see some pretty big Medicaid numbers probably over the course of time.
Thank you.
Farmers markets, I guess I've been getting calls that people at farmers markets, they may not have gloves, they may not have masks.
Yeah.
Are you working with Department of Health to try to come up with some kind of protocol for farmers markets?
I haven't brought it up to them. I think it's a great idea. We should have a simple protocol. They are doing social distancing.
We keep promoting farmers markets, but then, I mean, I noticed even at the drive-through.
The cities have been, we're told.
No, city only manages theirs, but they don't manage farm bureaus. They don't manage all the private ones.
Grocery.
Yeah.
So city only manages their city farmers markets.
Yeah. But
But you
gloves
would
and a
still
mask
need
would be-
Department of Health protocols for each one.
Yeah.
I just wanted to say, I guess we also have to ask the governor and DOH is that because we have a stay-at-home mandate or, we're still allowed to go out to places like whether it's doctor's visits or grocery store, whatever. And even going to pick up takeout food. I notice when you go into a building, supermarket, whatever, hardly anyone is wearing a mask. And to me, there should be a mandate to wear a mask if you are going to a building that is public, whether it's common areas of a condominium.
No, but this goes back to, I think, when we talked about the different levels of threat, different protocol levels, and so at this point, I would think if we're at orange, everyone should be wearing a mask.
That hasn't been said publicly by anyone.
Yeah, so I think part of that we have to check with HARA and we can check with Department of Health.
We've been asking for that, like if you reach X amount of cases, you need to move to the next level. X amount of cases, now you need to wear masks.
Yeah.
I agree. I totally agree. We in the previous iteration of this, we had that number at 500, and there was no magic to that. And they are actually producing, and you're going to be able to get a very powerful presentation, which Chair De La Cruz and I we sat in on it on, I want to say last Friday, and they are working that final draft now. So it was due today that they wanted to get all the input in to finalize it for the statewide plan, and it has triggers for things like when you trigger extra build out for rooms and so on.
So HARA's going to present, I think, maybe next week.
One of my constituents recommended that to minimize the number of people standing in line and so forth, like at Costco, to go on a odd and even type method.
Based on your birthday.
Driver's license or some ID, so people aren't, because with these lines, you can't predict how long you're standing in the sun. I've
Yeah.
been in one of them, and the people have umbrellas.
Well, PetSmart, theirs is pretty good. You just order it online. You tell them you're driving through. And when you're there, you open your trunk.
Costco.
Yeah,
Even the material store, the line was around the building just to
What I thought about this, what I would recommend, because they took my car from me for one thing, but would be birthdays, even or odd. If you're an odd birthday, I'm the 11th. You are on odd days, and if you're an even birthday, that's right. And that the only tricky consideration of that is if, like, Jamie and I happen to both be born on the 11th, different months, but the 11th. So we would both be odds, which would negate our ability to shop on even days. But you know what?
You
Big
don't
deal.
shop every day.
No, God forbid. I try to shop once a year. So, I get you. Yeah.
Can I also ask another question? Are you involved with the prisoner releases?
No, I'm not, although I have had lots of emails and input. Can I share my feelings about it? Okay, so there's the compassionate, worried position of infecting people, and then there's the concern that I have, which is if you release prisoners who are already antisocial in some way, I really worry that they're not going to listen to all the social distancing and home quarantine rules. So what my recommendation, if we're going to do that, would be either to pick a facility that we can keep some modicum of lockdown on, or use ankle bracelets, which is what I brought up with the public safety director. I do worry that close quarters could cause a mass infection. I'm setting aside releasing prisoners for a second, which is highly debatable one way or another. If we get a big outbreak in the prisons, and they tend to be poorer health, people have a lot of chronic disease, there were a lot of drug addiction cases going on, we could get a big surge that takes up our ventilators, in addition to having a lot of people, which would be terrible to see people die, and also terrible to see our capacity if we had a 2,000 prisoner population and 1,400 of them got sick. 1 out of 100 tends to be on a ventilator. That could overwhelm the ventilators of a whole region. So thinning the population geographically probably makes sense. Releasing a lot of prisoners, that's a policy call.
But here's the thing.
Yeah.
If you have this community, and the only way that they can get the virus if it's brought in, and if you're not letting any visitors in,
Yes.
and if you test the guards and you make sure that they're wearing masks and they're wearing gloves and they're doing social distancing, because they're not supposed to be,
Right.
I'm not sure of discipline or what is going to put you in close contact with
Right.
prisoners, but if they exercise those things within it, I think they're safer even though they're in close contact, they're probably safer because they're not exposed to travelers, they're not exposed to some of the community spread that might be happening, and you can test and you have a controlled group. Now, once you let out so many, and you're not going to let out enough to be able to have social distancing within the prisons anyway.
That's right.
I mean, if you reduce it by 439 or whatever, that's still not going to reduce the prison great enough to have social distancing.
Right. If you don't
But the community is now impacted by the 439 and what's going to happen. So, I mean, how does that common sense kind of thinking works with just, an excuse to let out prisoners early?
Right. So the several points I would agree with, almost all of them, is number one, you could thin the contact and get social distancing if you wanted to put nonviolent prisoners in, say, tents or in spaces on the ground, still in protection, but not in very close quarters. 1. 2, you're correct. We have had reports from prison staff that they're not having adequate PPE, personal protective equipment. They must be included in the distribution of PPE to keep them from spreading, because you're right. Overall, if we do that, giving people masks, the guards and so on, then prison is safer than Costco, if I may. So, but if you release, 10% of the prison population, you probably are releasing many, many people with antisocial personality traits, which they will not listen to whatever rules you or the governor come up with. So,
but releasing 10% is not going to lower the percentage of the people in a prison anyway. Unless you release 50% of them, you're not going to achieve what you're hoping to achieve, and the unintended consequences are huge. So like you said, if they can put, people that are infected,
Yeah.
that test them, because you have a controlled population, test them, put the ones that are infected, like you said, in tents or whatever you need to put them in.
Right.
But then the rest, once you deem that, you can control that.
And actually, I should have mentioned this earlier. One of the things, the benefits I thought about these rapid testers, these 15, they're going to have a very, very diluted benefit in each county or island.
Yeah.
But at facilities, they could be quite valuable. And in those facilities where you wanted to suddenly test 15 prisoners to find out, okay, I got to get these guys away from the population, big benefit. Also, we can do same-day testing on if we had to do 15 or 20 of the prisoners. So,
Well, wait. But tomorrow we're going to meet with them.
Right.
And
no,
so
but
tomorrow we're going to have
get a doctor's opinion as to, these thoughts on the fact that we're not going to really bring that population down. And
So just put it in perspective.
okay. Thank you.
Senator Keohokalole has a question. Senator Favela has a question, and we still have Riker. Okay. Do you want to finish then?
I'm done. Go ahead. Thank you.
Okay, go ahead. Senator Keohokalole.
Thank you, Senator. Can you, for being here and giving your thoughts on these things, can you comment on the PPE situation? I know that there's been a lot of progress made on acquiring sufficient PPE for the healthcare community. At what point do we reach a comfortable or critical amount of supply for the healthcare community before we can start saying our ancillary service providers like mental health, substance abuse, prisons, public safety, first responders now we can start acquiring PPE for them? Can you kind of talk about the strategy there?
yes, that's a great question. So we're 20 to 30 days is my understanding of PPE on hand. That can change somewhat quickly if we get a spike, and today's situation in Maui is, for instance, going to cause a small spike in need, and they're going to have to get extra PPE. But they did get, I believe, 28 pallets in the last 48 hours of PPE, many hundreds of thousands of PPE. So lots of PPE available. We also have reached out. We have, in the coming days, we'll be able to do some announcements. Some philanthropy will be bringing masks and additional PPE in, specifically for the other groups that you mentioned, so we can distribute to them. I will say this. I think it might be prudent, and you have to make a decision on this. It might be prudent to ship masks, at least, and you can choose what quality of masks to every residence and do it bulk. You can get you could do a very large buy. If we're talking about 300,000 or 400,000 residences times 10 masks, say, you could ship, and I'm not talking about N95 masks and taking them away from healthcare providers. You could provide some extra protection if we go down the road of, say, requiring at orange or red masks for everyone in a closed or public building. That is one thing that the government could do very quickly with resources. Remember, these resource numbers are very small compared to the billions of dollars that we're going to be facing in losses. And the best thing we can do is curtail the spread and actually bring down the dates, the number of weeks or months that we're in essentially economic lockdown. We could right now begin to distribute some PPE to other organizations. However, the hospitals, as you know, remain the most critical need and could see the greatest, they offer the greatest benefit because they prevent spread.
But is Haima prepared to do that?
Which part?
Mailing it out to every house?
If we did an order, we could do bulk mailing. It would be a cost item. There's no doubt.
But is Haima prepared to do that?
This is just the beginning of that discussion, which I do have people that are bringing 1 million masks, for instance, into the state.
Well, it has to be part of their plan, because if not, because just like him, we can recommend all we want, but if Haima and Anderson and the governor say they're not going to do it, then it's difficult.
Mailing a mask doesn't necessarily mean people are going to use it. I think people have ways to get a mask. We've shown all kinds of ways to use paper towels, to use, T-shirts. I've seen people with bandanas. They're very creative. So I don't think it's a fact
stay
that
home is
they need
probably better.
Yeah, they need to mail a mask. The cost to mail a mask and give a person a mask that you don't know how many people, to me, we should mandate a mask and people can find ways to doing it. I think that money should be used better to put it into the prison guard.
So if I can ask a follow-up is, if we're still continuing to ask and the Haimas break out of the different tiers of alertness or threat, I would like to see some sort of standard set for when we have some level of sufficient capacity of PPE in the healthcare community, and then who gets PPE from there out. I would love to send a pallet of masks to every person. That's the federal government should be on that. But when do the police get masks? When do we have enough for the healthcare community so that the police get masks? And if I can ask one more follow-up question since we're in the resource discussion. Yes. Lieutenant Governor, can you share your thoughts on the separation of isolated cases? In Taiwan, they do an app. Taiwan and South Korea, they do a tracking app. They force you to download. In Hong Kong, they do an ankle bracelet. And in China, they just took children, elders. If you get infected, they just took you, and you go to a camp. At what point do we end up in that scenario where we're trying to pull away people to get away from their families because of the multi-generational household situation?
Great question. So what I would say is this: we are not there yet, and that's the purpose of having the guiding document and plan of yellow, green, yellow, orange, red. To separate people from their families, what we have the capacity to do is put people in hotels, and we've already priced out some hotels that we could simply rent out: an 80-bed hotel, 80-room hotel, a 60-room, a 200-room hotel, and that's the point at which we could easily separate people. And I do think it would be very prudent to separate our kupuna from large families when there's a positive in the family, if there's 6, 8, 10 people, because the likelihood of spread is very high. Regarding getting pallets of masks and so on, we are starting to look at, from the private side, ways to source hundreds of thousands of masks to police, fire, and so on, even clinics that don't get any service from the hospitals. That's all absolutely going on in real time. Those questions are probably a little bit better, if I may, for Hilton Rathel, who runs Healthcare Association of Hawaii and who's the centralized, I would say, arbiter of PPE. But I would recommend personally that we're talking about this constantly, preparing or getting some hospitals. We have one plan already for healthcare workers. I think that the lodging and tourism folks are put up $500,000 to pay for hotel rooms for nurses or doctors to stay away because they may be at higher risk for infection from their large families. It would be prudent for us to do something for that class, probably something for those who are suffering domestic violence. It's a surge that's a concern, and for separating large families to give them some space while people recuperate. And the final group, of course, is the homeless community, which we have some plans in the works for homeless rooms and maybe even some small villages. But the fastest way to take care of these things is with hotels if they're willing to do it, because it's just a price and a number of people that we put in. Does that sound okay, Senator?
Senator Favela?
Just touch on brief. I know you've been getting emails about we just talking about the prison. I know we're going to probably have them tomorrow, and I'll bring it up. The simple fact is that we have organizations on the island, in sober houses, and people that be able to monitor them, because that was the concern that I had. So my constituents reached out to me that we do have homes that provide these kinds of care to prisoners that will be released. So hopefully going forward that we can work with these organizations to make sure that, we don't want to just release them and then they go out there to have no job, no home, no place to go, and then they'll just end up recycling and going back into the system. And then it endangers not only the community, but law enforcement, first responders, because they're going to have to respond to the incidents that will be happening. So I just hope and pray that they really look into this and not just releasing our people that is incarcerated out into the public, and be more responsible going forward.
I think that, and I would like to underscore a larger point that you're making about that, which is, please understand the way this is working is lots of input comes in and it actually is being absorbed and used. So consider yourselves a full arm of the advice to General Hara and the team. So when you have the conversation about release or other use of services, just tell them that's what you would like the policy to be, and I will, of course, share that too. And it's a very sound policy that could be utilized. It also keeps some people in work. If you do send the prisoners out to the street, they just join the homeless population in clusters, and they will spread the disease just as badly as they would have in prison. So it would be prudent just to give very clear guidance to each department what you expect. And I actually think it's going to be, if you're direct, it's going to be honored. And I hope that you'll be very direct with the Department of Health, because that has been a frustration for me. I think that mistakes have been made, though they're doing a lot of hard work, but mistakes have been made based on an extreme connection to CDC protocols, which have not helped us. CDC has failed us with testing, with kits, and with a lot of their guidance.
Thank you.
Okay.
Thank you.
Okay, well, if we have other questions, we're trying to meet periodically.
Yes.
We don't want to be hindering any progress, but, so, thank you.
Thank you.
Yeah, it's good to see you.
Thank you.
Thank you.
Okay, so members, we did have a change in the agenda. So 11:30 is going to be Director Wada. 12:30 is Kenneth Howard calling in, and at 1 o'clock we have Dr. Anderson. Okay, so
Thanks, guys.
Thank you.
Sorry for going long. I appreciate it.
Thank you.
Director Wada, are you on the line?
Aloha, Senate Committee. Can you hear me okay?
Yes, thank you.
Okay, great. Thank you, Riker Wada, for the Department of Human Resources Development. Thank you for the opportunity to provide information. I did send in, and I apologize, it took, I just sent in within the last about half an hour to 45 minutes, 2 communications to the committee. The first being the list of Category 3 employees, and then the second was in response specifically to Senator Mercado Kim's request regarding the DHERD employees. I did receive from the committee as well a list of questions, and if it is okay with the committee, I'll just go through with responses to the questions unless you would like to just ask instead. Okay, hearing no objection, I'll go through the list of questions I got from the committee. The first is, if the governor suspends collective bargaining in order to reassign non-essential employees who are sheltering in place, how and by whom will the decisions be made to assign staff to other departments? The actual decision will be made jointly between Incident Command, the governor, and DHERD. Incident Command and the governor have the decision-making ability to where to assign particular staff or particular requests from departments. DHERD on our side will be assisting in figuring out which of the Category 3 employees would be most, or would they be able to do the work that's being requested by the departments themselves. Question number 2 was, how many non-essential staff would be affected? What PPEs would be provided to assure their continued health and safety and reduce the risk of community spread? So the total list that was provided to this committee for employees in Category 3 is, hold on one second, the total I believe is 706. We don't know how many of those Category 3 employees will be redeployed. It's all dependent upon the requests and the need of the department. What our general guideline is for any department requiring or requesting additional assistance from redeployment, that they are to certify that any of the new employees coming over have the adequate training and equipment required for any of the positions that they're going to be filling in. Additionally, we're requiring any of those departments to abide by any social distancing or safety measures as appropriate via policy or the Department of Health. Let's see, just how, question number 3 was, just how shorthanded is the Department of Labor and Industrial Relations and the other state departments? In short, DLIR is looking for 89 employees. Currently, they have reassigned within their own department 39 employees, so DLI employees who are now helping out with unemployment insurance. they're requesting assistance for an extra 50 positions, 50. And so if eventually the 39 internal DLIR employees will have to go back to their regular jobs to accomplish the work that they're already doing and not just the crisis management for unemployment. So eventually the total will be 89 as of this point. Regarding other state departments, we have not, DLIR is the furthest along in our process of requisitioning extra employees or additional employees. So for the other departments that we talked about in the last hearing, I do not have a number for those departments. The departments have not provided specifics about the class and types of work and the numbers that they are needing right now. And so we're following up with those departments. How many state, question number 4 is how many state employees are non-essential and non-telework for each department? So this is the earlier question. The total number is a 706 per department, and I'll just read through these. DAGS, Department of Accounting and General Services, is 46. The Attorney General is 171. DBED is 9. DCCA is 3. The Department of Defense is 110. We have this listed down and it'll show up on your worksheets as well. Education / Hawaii State Public Libraries is 241, but what we should note there is that's all libraries. We did not solicit this list from the DOE. DHS is 43. DBIRD is 2. The Department of Health is 28. The Department of Labor and Industrial Relations is 24. And the Department of Land and Natural Resources is 29. What is the plan for using these employees? So currently, as I mentioned in the last hearing, DHERD has solicited requests from departments for additional assistance. The same departments that we talked about last time are the departments that have requested assistance. And we did follow up with DOBAR and DBED. DOBAR is in the process, DLNR is in the process of asking or soliciting from their own department what kind of assistance they need. DBED has not responded to our request yet. Question, I believe it's 5 or 6. What is the plan for 89-day hires? Are they all terminated or are they doing some essential work? So this is a follow-up, I believe, to Senator Mercado Kim's question. We are soliciting that information from the departments now. Some departments have deemed some of their 89-day hire employees as essential. So those employees continue to do work and continue to be paid. Other departments have deemed their 89-day hires as non-essential and non-telework, and so they themselves may be, like, for instance, in DHERD's case, may not be coming in and may not be working. And then again, there's the middle category. There may be some employees, 89-day hire employees, who are able to do work and they're doing it remotely. And so that determination is left up to each of the departments. We are attempting to gather that information from all of the departments right now. What are the, and I'm sorry, the last question that I have here is, what are the needs for additional staffing by department and what's the redeployment plan? Those are the pieces that I spoke about previously. The departments, the 5 or 6 departments that we had indicated last time, the department right now that has the most, is furthest along in the process for redeployment is DLIR, and so we are working dual track on the volunteers who are to go over there, as well as redeployment of employees further along in the process. And I think that answers all of the questions that I was given, and I'd be happy to answer anything else.
Hi, Riker. Thank you for all the information. I go back to the Labor Department because that is the greatest need. We're seeing a lot of complaints coming in because their system isn't working. They don't have the call center up. So the 89 employees that they need it today. So how long, in terms of getting them the help they need immediately, is being worked on? Is it going to be, taking these positions and trying to see who's in the right class, or is it just this is the kind of work that has to be done in making a call? Because this is, necessary to get them staffed up like today or yesterday.
Sure. Thank you for the question, Senator. So we have been working with DLIR, pretty much constantly regarding this particular issue. So to be clear, for the 89 employees the positions that they're looking for, 39 of those are actually already filled with DLIR staff. So we're working on the other 50 right now. And as the 39 matriculate back to their own positions, are returned back to their original positions, we're going to be filling those needs as well. There are two, and I'm sorry, I'm not entirely well versed on DLIR's operations, but basically there's two pools of employees that they're looking for assistance with. The first is like a call center type employee who's basically doing customer service and assisting assisting claimants in filling out applications or following up on applications. The second pool are those employees who are actually reviewing and vetting UI claims. So in terms of timelines, the volunteer process is well underway. We're in the process of, what's happening is the departments have solicited from their own employees people who might be willing to volunteer, and if the department can spare those employees, they're sending those employees to us. And what they're sending is the employee's name, position number, and job, so that we can see what their background is and see if they're actually appropriate to do that. So the volunteer process will likely be turning around. I'm hopeful that it will turn around. I was going to say Friday, but I didn't realize that was a state holiday, but it'll likely be turned on Friday or Monday. Ideally, the redeployment process will happen at the same time.
But they're not really volunteers, and it's not like... Can you clarify that?
So yeah, sure. So like for instance, what I did for our department, for DHERD, is I sent an email department-wide, and I said, hey, is anyone willing to go? This is what DLIR needs. Is anyone willing to go and help out? So what I asked our employees to do is then check with their supervisors to see if they were able to be, basically if they had the capacity to let one or two people go over and help DLIR. And then once we get that list of the people where the department and the employee agree that they can go over, we are then sending it to the people who are vetting this to make sure that they're appropriate for the type of help that DLIR needs.
I get that. I'm just saying that they're not volunteers.
They're being redeployed.
They're not volunteers. They're being redeployed.
They are being redeployed, but on a volunteer basis. So you're right in that respect, but it's different from the redeployment of the Category 3 employees that we were talking about earlier.
So Riker, just one follow-on then, because I look at these 706 in the non-essential, non-working group. There's a lot of people like office assistants, clerical, that support payments officers. That could very well qualify. So how are you gathering these people? Let's say the 89. Are they going to the department saying, this is the competencies we need for Labor Department, whether it's a call center or the other payment, looking at the certification, and asking, does anybody have this kind of qualification, rather than who's volunteering, because that could take a long time to get people volunteering, as versus these people are at home, can they do some of this work? How is that process going on? I'm just looking at doing this quickly because the problem is like yesterday and growing.
But wouldn't you be able to already know from position descriptions what skill levels certain people have?
That too.
I mean, why wouldn't you be able to just quickly identify those? send an email to those and say you're going to get redeployed.
Yeah,
Sorry, Senator, I didn't mean to interrupt you. Yes, that's exactly what we're doing, and that's why we have the detailed information we have on those lists is to look at the position to see if they have the skill set necessary to be redeployed.
No, but you don't have that statewide. You're saying every director now has to send an email on their own, and it doesn't sound like it's a form. It's not.
You're correct, Senator.
It's not a process. You guys don't have a system set up.
So, Senator, there again, let me try and make sure I'm being clear. There's two parallel tracks for filling so let's talk about DLIR. There's two parallel tracks for getting DLIR extra assistance. So the first is what we are calling, and you're right, it's not technically volunteers, but because it's their current state workers. But the first track is for a voluntary agreement between an employee who would like to help out DLIR and their supervisor / department, so that we could just send them over. So for instance, if there was an office assistant who wanted to go help out at DLIR, they would contact their supervisor and say, I'd like to go help out. So that person is then sent to us. We look to see if we're able to, if it's a skill set that DLIR can use, and then we send them over. So that's one track.
What if they don't? What are they doing in the meantime?
So those people, they're working. They're currently employed, and they're currently doing their job.
This is the bucket 3 people we're talking about, right?
No. So, and I'm sorry, maybe that's where I'm not being clear. So this voluntary track that we're talking about is for people who are in the first two categories. So in those first two categories, if a department can spare someone to go help out at DLIR, then that's the volunteer process. The secondary track process, the parallel process that we're talking about, deals with that category 3 group of employees. And so that is not a voluntary process. Once we start that process, which again will hopefully be Friday or Monday, what's going to happen is we're then going to tell those employees, you have to report to this particular work site. You have to report to DLIR at this work site at this time, and this is the type of work you're going to do. So that redeployment process is not voluntary. That's a redeployment for those employees.
So Riker, so why do we need to go to the first choice of volunteering? Because it seems like it'll take a lot of time. Plus, these people are supposed to be essential workers, either at site or at home teleworking. So it seems to me that bucket 3 is where you should go to immediately and say, hey, these are the kinds of skills we need, and who, identifying who they are, and then just getting those people already just to shift over and redeploy. Because if you have volunteers, that they're already supposedly essential workers. That's why they're in buckets 1 and 2.
Sure, Senator, and I can appreciate the concept. Really what we're talking about here is people who might be willing to work extra, just volunteer their time. So for instance, there's a fair amount of volunteers who, what their intention is to continue doing the work that they're doing for their regular department. And then if they can, they would work 4 to 8 hours after their regular shift to help out DLIR. What that's going to depend on is if DLIR can use those people. So we have a fair amount of people who are very generously volunteering to go help out at DLIR, and where the time comes in and the complexity comes in is trying to match up those skill sets as well as the logistics of when they can work. So the reason we stood up the volunteer process is we were not sure how long it's going to take to stand up the redeployment process, because it is something that we're consulting with the unions on.
So Riker, short of not redeploying these people, wouldn't furlough then be the next the next logical step. So if you're talking to the unions, I mean, if they're not doing anything, I mean, there's a lot of people out there who have lost their jobs, who can't even get the unemployment, and they're seeing that we have workers, state workers, that are getting paid and not doing anything. So, it would make sense that these people would want to keep their jobs, but obviously if they don't have to, if they can just stay home and not do anything, they're going to choose that. So, a lot of the complaints we're getting from unemployment is that people are not getting calls back. They're not being told whether or not their application has been even received. Now, you're telling me that we can't get these people, can't make phone calls? I mean, they have to have a special skill set? I mean, there's a lot of things that people can be doing, just getting a list from the other, calling people and letting them know, yes, we've got your application. Yes, this is, I mean, those are the kinds of things that we need to get people doing, and they can do that from home, and we have them sitting there already not doing anything.
Thank you, Senator. I appreciate the comment. So yes, that's exactly what we're working on right now. DLIR has just recently shifted some of their plans in terms of their alternate work site to using it as a call center as opposed to using it for a claims processing center. And so we have had to shift a little bit about how we're looking at getting people into those positions. Regarding your question about furloughs, that's not something that I'm able to answer. From my information, my understanding is that the state pays into its share for unemployment insurance based on usage. So for instance, if 100 state employees were to access unemployment themselves, the state would be paying for that. So I'm not sure if it makes...
I'm not advocating that we furlough. I'm not advocating they go on unemployment. I'm just saying that if you're working with the unions and we want to get these individuals redeployed, that certainly the only alternative left would be, if not, the furlough situation. So I think we have a very good argument to make sure that we move quickly and we get these people doing stuff. I think they would want to make sure that they can keep their jobs and keep their medical as well, and making phone calls and calling people back and keeping in touch, I'm sure are things that can be easily done. Why does it take us so long to create this wheel? I mean, it shouldn't be that difficult to do.
Thank you, Senator. We have again been working on this, and so we've had very positive responses in terms of partnership with our unions on this particular issue. So, like I said, what we're hoping to do is stand this up by Friday or Monday.
I believe we do have good working relationships with our union. I just don't want the administration using that as an excuse why we're not moving quicker than we should be moving. I mean, we have so many people don't know if they're going to get an unemployment check. They don't even know if their application was received. So these are the kinds of things, and it's causing them mental distress. It's causing them, we're having all kinds of other problems because of that, because they can't even get a phone call back. So we have to move quickly, and I don't want to hear excuses of why we're not moving quicker.
So Riker.
Thank you. Well noted, Senator.
No, wait. So when can you get it done?
We're hoping for Friday or Monday.
Okay, so so on Monday you can report to us that it's complete.
That is our goal.
Could I suggest you also work with Labor Department that they are not, as Senator Kim said, they're not even getting a response back either on their website or by a person, a body answering something, because they can't get through that. If they have these people to at least call people and say, we've got your application, that's a simple 1 minute or 2 minute call to reassure these people that they're in, that their filing has been confirmed. If you could work with the department also to look at how they might more quickly respond to the public, and maybe they might need more people, but they're just phone calls, just saying we got your application. That would be really helpful to a lot of people in distress right now.
Well,
Thank you, Senator. We'll definitely work with labor on that.
My understanding is that the Director of Labor is willing to do whatever training needs. He just needs the bodies.
Well, but it's different.
Senator Kidani.
Thank you, Riker. I have two questions. The first is, in going through your list of those that are non-essential and cannot do telework, I noted that in the Department of Education, there are 250 library 3, 4, 5, and library techs. So when you have that many, and I don't know the differences of their positions, what exactly they do, but when you have that many, and that's a significant number to me, 250 in the category of librarians, is there any follow-up with the departments to see what the, to look at what their job descriptions are and how, you know, why they could not be used for certain kinds of telework?
There is. So part of our process regarding telework or assisting other departments is getting the requests for from the departments that need help. And so, you know, as we talked about in our last hearing, there are about 5 or 6 departments who have indicated that they're looking for additional help. And as I mentioned, DLIR is the furthest along in that process in terms of providing DHERD with a position, types of work, work site location, for us to be able then to look at those categories of people who are in category 3 and to see if we can redeploy those people. So we don't quite know exactly what the total need is right now because we haven't gotten more detailed information. But for DLIR, that's what we're focusing on right now, is because we know what their need is, we're focusing on vetting the list we have and then sending people over.
Okay, I'll pass on my other question. Thank you.
Well, I thought DBID said they also need people for a call center.
You know, I know the committee had mentioned that at our last hearing. I specifically sent a communication to DBID and I haven't received a response yet. So I'll continue to follow up with them, Senator.
Okay, it still concerns me though that the approach is a little bit, I guess, haphazard. You know, you send out an email. I'm not sure how you can communicate that to other directors to send out an email. It's not like it's a formalized process. Why is that?
Well, Senator, I mean, it's the process that we have. I think is. You know, I don't know if it's just semantics or if it's just perception, but for us, it's a formalized process. We're requesting, we need to know what the need is.
No, so what kind of forms do you give? Like when we do budget forms, we give each department all the different forms to fill out. How do you do that with, how are you asking other departments to do the same thing that you're doing within DHERD?
Well, we're asking the departments to tell us what positions they need filled. So, or what types of work they need help with. Yeah, so once we get that,
they fill out a form, or do you get it back in many different ways? Each department just kind of filling out their own memo?
You know, I'm not sure, Senator, because we haven't gotten the responses from anyone except for DLIR.
So my concern with that is that that's why I think it's going to take additional time to process. Because if every single department is just communicating on the fly, versus you sending out some formalized form that they can fill out, then your department can process that quicker.
I don't think for DHERD we have a problem with turning it around quickly. We just haven't gotten the request.
Okay, well, there seems to be a timeliness problem. I'm not sure where it lies then, if you're telling me that you have it all organized.
Well, Senator, you know, in response to that, what we can probably do is I'll create a form to send out to the departments, and we'll resend that today.
Yeah, and if you digitize it, you know, it's electronic, and you say, this is what, tell us what you need. They can send it to their divisions and their branches, you know, because again, with Land and Natural Resources, Jobor had the request, but you know, it goes up the stream, right? So in a way, if it's really simple, tell us if you need staff.
Well, you can follow how we do budget instructions. instructions.
And then just get it fast back electronically. Then you can use that to process when you need other staff.
You can follow how we do budget instructions. We give budget instructions to every single department with Form A's and Form B's on how they have to fill them out and return them.
Sure, well noted, Senator.
I mean, Erin is there. She should know how to help you do that. Senator.
Thank you, Senator.
Riker, I decided to ask my second question anyway. Is DHERD looking at any possibility of doing early retirement plans for some of our workers, particularly if they're non-essential and they have a certain number of years?
Senator, I know there have been, this is similar to a question that was asked not the topic, but in my answer. So there have been conversations about this particular idea. DHERD hasn't really been directly involved in it. One of the concerns I think that's been brought up is if early retirement was to be offered, there are two possible issues with that. One is there's a significant, and as I think several of you are aware, there's a significant number of our employees who are eligible or close to eligible to be able to retire. And so there might be a capacity issue in terms of losing that much institutional memory across our departments. The second piece being, if in fact there was that type of mass retirement, that actually might not result in any type of cost savings, as a lot of our retirees have quite a bit of vacation that they would be entitled to that would have to be paid out.
Well, I'm not really looking at it as a way for cost savings to the state. I'm looking at it as more of a time that in this transitional period, we know that we're going to lose people who are up there, and yet we don't have, I don't think a lot of the departments have a transition plan, nor will that be their first priority after all of this is over.
Sure, that's very well noted, Senator. And I think the conversations are going to continue to happen.
And we'll have much more people who are going to be unemployed.
Okay, you know what I think we're going to have to do is, because DHERD is taking so long, we can come up with similar instructions and forms, and we can just send it out to the departments, and then we'll copy you. Would that be helpful?
I think it's duplicative, but I'd be happy for any other type of assistance that the Senate committee is willing to provide.
No, so you tell us. If you can't get it done, then we'll help you try to get it done, because I'm not sure what the issue is.
Senator, like I said, we've solicited the requests from the department. So, I mean, maybe if the departments are more inclined to answer the requests from this committee, then the help is welcome. But again, just to reiterate, we have sent out the request to the department.
Okay, that's something that we might have to consider then.
Can I ask one final question? So, Riker, according to what you said earlier, 89-day hires, there are many that are deemed essential. So, don't you think that this is something that possibly need to be worked on? Because I have been talking about what is the purpose of 89-day hires? Why are we filling positions, essential positions, with 89-day hires? I know in some situations you can't find the people immediately, but these are not supposed to be positions that last years and years, which we're finding that's what's happening with 89-day hires. So just by you saying that they're deemed essential, it'd be interesting to know of all the 89-day hires, how many are deemed essential, because they should have been positions that were filled.
Yes, point well taken, Senator. In response to your last emailed questions, that's what we're actually trying to get a better hold on. In the list that you guys, the list of Category 3 employees you got, that it didn't address the 89-day hires and what category they're falling into. So we're following up with all of the departments right now in order to try and get a better handle on which 89-day hires fall into which categories. And so that's a follow-up correspondence that we're going to be sending to you as soon as we get that data.
Thank you. I appreciate that. But I think this is one of the points the committee is making out. Instead of doing it the first time around, now you got to go back. You give us a list of 89-day hires, but you don't tell us anything. So I think when you ask the question, you should ask complete questions so you get the complete information. You don't have to keep going back. Instead of saying, how many 89-day hires do you have? Give us a list of your 89-day hires. What are their positions? Are they essential? That shouldn't have been the first thing you asked.
Senator, you're probably right, and it was my mistake. I did not understand your question from the last hearing, and that's why I provided you just the numbers of 89-day hires. So again, I'm much more clear about that now, and that's why we had to circle back. So that's my fault. I apologize for that.
But Riker, in all due respect, it's not necessarily what I'm asking. Isn't that information you should know? Isn't that information that would be, help us in this situation and not wait for us to ask it? And so we ask a general question, shouldn't you turn that into a more thorough request?
Senator, yes, and I appreciate the viewpoint. When we designed the process of the 3 categories of employees, it was primarily revolving around number 1, social distancing and governor's policy. But secondly, we were really giving deference to the departments to determine their own operational needs. And so, for instance, if a department had someone 89-day hire in an essential position when this happened, they would not be able to fill it with a regular employee. And so that was...
Riker, we understand that. We want data. We want information. So whether it's left up to the department or not, it'd be good for us to know that. Good for you to know that, right? To know which 89-day hires are essential, which 89-day hires are not, how many is being laid off, how many, right? Isn't that information that you should have?
I think it was not information that DHERD is necessarily in need of, but again, per your request, we're going to get that information as soon as we can.
Okay, well, I think that is information that you should have. So hopefully in the future, those are kinds of information you will continue to have in your database. Thank you.
Thank you, Senator.
Riker, can you send us a copy of the memos that you sent to the different directors?
Yes, definitely. And they're primarily emails, so I'll send copies of the emails.
Okay. I'm still concerned that there's not a formalized process in how to deal with this.
Okay, and like I said, we'll create a form today, and we'll resend that out to departments regarding their requests for assistance. And we'll copy this committee on that form as well.
So when you don't get a response, and obviously there's urgent matters that we have to deal with, a lot of people at DLIR, or a lot of constituents need help from DLIR. Who do you go to? Do you tell the chief of staff, hey, I'm not getting any response?
If in this particular case, we sent out the request to departments and we're just waiting on follow-up from them. The only department that was mentioned in the last, well, I should say the 2 departments that were mentioned in the last hearing are DLNR, DOBOR, and DBED. And so we sent direct communication. I emailed both DBED and DLNR. DLNR did respond, and I think they're following up with any type of actual positions they might need. And as I mentioned, I did not hear back from DBED.
Okay, so I guess just to summarize then, you're going to take group 3 and you're going to start to move them over to DLIR, whoever you can.
Yes, that's correct.
And that's going to be done by Monday.
Yes, that's our target date.
Okay. I think the whole committee probably wants to reiterate the urgency that Senator Kim and Morwaki had mentioned, that there are people who are very stressed out there because they can't seem to get a response. They have rent to pay. they have bills to pay, and they're really concerned. So I hope that your team is working around the clock to try to get this done.
I definitely appreciate that, and I have the same concerns, Chair.
One more thing. So as you get these people, if you start this process, without waiting till you get all 89, could they be given to DLR as you get these people so that they can start the process? So at least you are meeting, because Monday is quite a ways away. When you look at people who are really concerned that they're not getting their checks so that they can pay their rent. So if you can, as you get these people, do it immediately and push it through if you can. Thank you.
Yes, yes, Senator. That's exactly what we're doing. It's a rolling process. We're not waiting to get all 50 to send over at once. We're just as we get the appropriate positions and employees, we're going to be sending them over.
Thank you.
Okay. Thank you.
Thank you, committee.
Okay, why don't we take a recess?
working on this thing. I use it all the time.
Okay,
We could lip read you though, so watch out, yeah.
you want to start with any opening update?
So the biggest one right now I'm working on with the mayors today is coming up with the agreement on the alternate care facility based on some modeling that we did. So right after this call, actually, I'm going to work on that, and I'm going to work with each county separately. We had a policy meeting this morning, and they just wanted to do this by email, so I got that. And then tomorrow, that plan, Secretary Cruz, the briefing my guys gave to you on Friday.
Yeah.
We analyze that thing. We're going to sit down with Governor Ige Thursday afternoon, and then if he approves it, then I want to coordinate with the Senate, the House, and then later the hotel on briefing, either together or separately. Probably separately would be better for us. So we can come and brief your committee on the entire plan, and then the House side, and then working with Senator Shaw to get the other hotel members.
Okay, so we can organize that sometime next week.
Yeah, sometime next week would be best for us. So even maybe by Friday we can get it together, but probably not. I think next week, early next week would be better for us.
Okay, so like Monday or Tuesday.
Correct.
Okay. Okay. Well, we'll I guess by Friday you can let us know what works for you.
Right. And then did you guys get word about the cluster at Maui Memorial? We believe 50 healthcare workers.
Yeah, we read about that.
Yeah.
Okay.
Is that where one of the deaths were from? There's a reported death in Maui today.
No. The recorded death was someone who was with severe underlying conditions. I heard that person was already terminal, and the COVID just made it worse.
Thank you.
Yeah.
Jenna Hara, thank you. It seems to me, and I think the rest of the committee members, that there is an increase in visitors coming to Hawaii. Can you address that? And, this committee has requested that the governor sign the letter to the president requesting that non-essential travelers be stopped. We're not asking the airport to shut down, but that, but it seems like there are more and more, from yesterday to today, it went up.
Yeah, it's irritating. Trust me. So we are watching that. We're also going to start trying to track the inter-island, the reasons why they're going back and forth. I did have a very good conversation with Deputy Chief McCarthy on enforcing some of these people, because most of them that are flying in, I'm quite certain they're not following the self-quarantine order. So they're going to step up enforcement, and he committed to that. So I really like the partnership with HPD, and we're doing the same thing on the other islands. As I mentioned, we stood up the state law enforcement coalition, so we're also getting the other state law enforcement involved in helping with enforcement. So Billy Oku is a lead of the SEC with assistance from Mike Vincent, and then we got plug-in from all the county law enforcement and all the state DLNR initiatives. So I got that going. Going to have a conversation with the governor. We may look at mandatory quarantine at a location that we control. So they arrive, we test them for their temperature, we put them on buses, and we take them to a hotel room, and we mandate the quarantine. So not self-quarantine. So that may be the next escalation in policy. Governor and I had that discussion yesterday.
And can we charge them for the time that they're quarantined if they stay at a hotel room?
I'm not sure. I got to work with the AG on that.
Okay, well, it just concerns me that, one, we're going to use law enforcement time and energy to have to, be more diligent in enforcing this stay at home, and then we're going to put them up when we should just not have them come in. I mean, it's costing us more time and effort and using our resources.
But we don't have the authority to stop it. We tried, and
Well, the
FAA came back.
But the governor
Absolutely do not
didn't
have
sign the letter to the president. The president said he would, when the mayor's asked that he needed a letter from the governor. So can we at least get a letter from the governor asking him? I mean, we haven't tried everything, and that's one that we haven't tried yet. Right?
Correct.
So, is that something you can talk with him about? Because the people
I can talk to him about it. There's just some unintended consequences that may come up on it, right?
Well, how much more unintended consequences than what we have now? I mean, unintended consequences would be to have to put them up in a hotel room to utilize our law enforcement when they should be doing other things. To me, that's the greater unintended consequence. The residents out there are not happy. Our constituents are not happy that this is continuing to go on. I mean, we started the 14-day quarantine, took him 5 days to do the quarantine before it went into effect. We said it should be Neighbor Island, didn't do Neighbor Island. Molokai had no cases. Representative Court had to call me and say, can you folks insist on Inner Island? Remember when we talked? We talked about Inner Island. Governor didn't institute Inner Island. Now he institutes Inner Island. I mean, it's like, after the fact, what is it going to take before we do this? We're up to over 400 cases and growing.
To me, Major General Hara, to me, asking local residents to lock down and allowing tourists in is like having a peeing section in a swimming pool. It makes no sense.
Right.
Okay, well, if you can just share those comments with the governor and or those concerns.
I agree.
And if you can somehow capture the intensity and sense of concern.
I got it.
I just have one.
Wait. Senator Keoho Kalole.
Senator Fabella.
General, so the governor's chief of staff also alluded to these unintended consequences. I think what would be helpful for the committee is if you folks could enumerate those consequences for the committee and for the public, so that at least the justification and the policy implications behind these decisions are transparent, which I think is the point of this committee. So if you could help us just bring out what's the justification so that there's transparency in that would be really helpful. My question actually is about PPE. I asked the Lieutenant Governor earlier today what conditions would necessitate or allow a coordinated acquisition of PPE for non-healthcare essential workers, first responders, all the way down to the grocery store workers. At what point are we satisfied with the supply of PPE for healthcare workers that we can start to coordinate with the counties or with the business community to get PPE to the prisons and every.
So we are working on that. For me personally, I would feel comfortable when the healthcare workers have a supply of the critical PPE that they need, particularly the N95 respirators, for at least 60 days. And then we are ordering more in bulk, right? So especially waiting on the federal dollars, if it gets here, then we can start making huge purchases. But we're talking like in the millions. We are purchasing every single day. But right now, I've barely met the need for the healthcare workers just because the burn rates have been high. And we actually had to go back and relook at the modeling and the forecast. We had predicted, I think, what the burn rate was going to be. And now, after what they provided me, I think it's really, really an accurate model on what the burn rate would be going into the future, especially if there's a potential surge and a spike. And that's what we're starting to order against now.
Senator Milwaukee.
Thank you. Hi, Major General Hara. I have a couple, just one on going back to the transportation. How are you relating to DOT airports? Because they said we aren't doing some of the testing. So I saw that some of your National Guard are doing that. But there's two parts to it. One is the testing when they come out of the, if they're disembarking, whether they're residents or visitors, that they actually have a place to stay and somebody checking that it is a legitimate place to stay. And number two, the self-isolation quarantine, who's checking on them that they do stay in their rooms for 2 weeks? And do you have staff, or can we allocate staff to help do that kind of checking? Because it seems to me that that's where some of the problem is coming, because people are going out.
Okay, let me talk to the first part first. So the airport, the National Guard just started Sunday. And what we were doing initially was using agents from the airline so that we could keep them employed. So they use their employees to do checking of forms, and obviously that's not what their forte is, right? We are on Honolulu for sure. I know we're using Roberts, and they're doing a really good job. I went to the airport today. We visited the checkpoints, visited the soldiers, went through the line and everything. Got my temperature checked. So every visitor that comes off the plane gets the temperature check. The only exception was based on FAA for the airlines. If they refuse, so they would get the temperature check, go to the hotel. If they refused, then we would do the mandatory quarantine for the airlines. And then for inter-island, the temperature screening is done before they board. So even before they go through the inter-island form, right? And then now what we added is the order that we had for what the penalties are if you don't follow. So we have the stay-at-home order, and then the penalties if you don't follow it. And then now each line they got to go in initial by, and then sign, and then the agent that takes information also signs and all. So that's something new that we only started yesterday. And that was asked of all the chiefs of police and they're the advisor of the attorney general. That'll make it a legal ID document easier for us to do arrests. On the checking, the only thing we're doing now is notifying the hotels where they're staying at, and then HTA is using their staff and doing the checks to make sure these people are in the room, and then we either get a call from the hotel or HTA coming up, hey, these guys not in the room, and then that's when we send the law enforcement. So that's currently what we have in place, but we're going to be wrapping that up more strictly, right? Like I talked about what HPD had committed to helping us with more enforcement. I hope I answered all your questions.
Yeah, just at the end, so the 14-day self-isolation, they shouldn't be getting out of their room. At the end of that 14 period, is there anybody checking to see that, in fact, they're testing negative so that, they are ready to get into the population?
No, we're not.
Again,
remember, we're not asymptomatic people yet. So we have a problem. So the test kits are not an issue. Throughput is a little bit of an issue, right? Some of the requirements are forcing the labs in Hawaii, the private labs, to ship the specimens on the continental United States for testing. That's where we got the long turnaround. What really is concerning is the swabs and the plastic thing they put it in. We call it the transport medium. That's the one that we got to watch. Because what I don't want to do is go all out, right? We start testing these people, we start wrapping up the surveillance without keeping an eye on where that limiting factor is, and then I run out of those swabs and the transport medium, then I cannot test anyone. I cannot even test the people that are symptomatic. So until I get that supply in huge order and looking at how the local labs can do more testing for us, I got to throttle that up slowly. I cannot just full throttle.
So we had heard from the LG earlier that there are these new tests, the FAST test, the Abbott test, and that we're getting some of those in, and that whether those are the kind that you could use for this kind of contact testing or the testing on quarantine people, so that it can be at least checked that they are not going out being positive. negative after the 14 days.
Right, yeah, so we are looking at future advances and how we can put that into the current plan. You know, there are risks too, right? But the worst case would be if we say someone tested negative, when in actuality they're positive, and then we have a cluster because this person, unduly thinks that they're not infecting anyone with the COVID disease. So that is the concern. The Abbott one, but they sent 15 machines down. The thing can test anywhere, like 20 to 40 minutes per test. So you cannot do multiple tests at once. It's one at a time. And the reagents for that test kit didn't match the amount of devices that we had. So if I'm not mistaken, I think it's only, I forgot the number. It's a low number. I was really appalled by the amount of tests that we can do based on the reagents and the new Abbott machines that we got. I'll look forward while you guys ask another question.
Okay, it's just in terms of the protocol to have that available at the end of their 14-day period, because that's when it should have been incubating or not.
But I guess what he's saying is that until he has enough supplies
but at least
to cover what he thinks, then he can expand.
No, thank you.
Senator Favela.
My concern is we are ticketing and arresting more locals out there in the community than our visitors. So that's one of the problems right now. The visitors that are coming here, they're getting warnings. The locals here are getting ticketing. They're getting ticketing for surfing, ticketing for being in the water, ticketing for the cars being certain places, but our visitors are not. That's one of them. That's my big concern. Another one is, same thing as Senator Donna and Senator Michelle said, we are gambling on the fact that we're going to use our local stressed out resources to babysit visitors. Just in case they have any outbreaks or clusters, like you said. We're going to use our valuable resources for the visitors that are coming here. They're not even preparing to stay and invest in our community, in our local community right now. That's the same thing that the Lieutenant Governor said earlier. But it just really bothers me that is not being pressed upon everyone that is involved, how important it is, yeah? I mean, I'm pretty sure, you know and I know, the governor can shut them down. You guys saying that you guys need the approval from Trump. Well, when Trump had put down the ban for having outside people from different countries coming to the state of Hawaii, we took them to court. And we would reverse the ban. So how hard it is, this is the problem we have here. President Trump said he gave each and every governor in each state to make the decisions, and he's going to back them up. So now it falls again upon the governor. All he has to do is make that request, and it seems like something is holding him back. We do not know why, and I just hope it's not to have more deaths of residents in Hawaii to make this decision. So if all the efforts was to say that he cannot, and the Trump said could, and then when he had to do the ban for like I said, countries not coming into Hawaii, they went fast. Hawaii was the first one to take them to court. So why can't we be that diligent and that pressing on our foreign people that were supposed to be banned from coming to the state of Hawaii? But then, why can't we do the same thing for the visitors? Why can't he just press upon his word, keep it in, and then tell us the truth? He can do it. You know what? I know he can do it because the President of the United States said he gave all the governors. Ask him, and he's going to help the states out. But our governor seems like not asking. And that's right now we've fallen upon deaf ears internationally because now we're hurting our residents. Now you're talking about hotels. Now you're talking about escorts with buses? I mean, these are all resources that our first responders and people could be accommodating for our residents. Our residents that maybe need to be in a hotel and self-quarantine because we have a large family. And we can't afford to get 7, 8 of our family members sick. That should be offered to us. I mean, we already offered them to first responders, which is okay, but it should be offered to us. And then the next question, that again is my final question. I heard that per harbor, definitely the word was per harbor, you guys had renovated a building back in December, early December, and probably finalized it in January. Barracks that could be used for all people that was positive on having the results to be self-quarantined there, to be monitored and have 3 meals a day. Do you know anything about that have a barracks like that was renovated on Pearl Harbor?
I don't know, but on most of the military bases, they have lodging that's run by a private entity, almost like a small hotel for people that are transiting.
No, that's not what I'm saying. I'm saying we took government money. Our government money had renovated this barracks in Pearl Harbor to prepare for this virus we're talking about. They made preparations in Pearl Harbor. The reason why I know that is because the constituents that live in Iroquois Point and the area that in the naval base, they all was in the area when that thing was ordered back in December. So I just want to know, how is that not transpiring? Because you're talking about hotels and everything else, all this other stuff. Why isn't it being looked into the barracks that was renovated for federal tax money to renovate this place, especially for what we're talking about now in the virus?
So Major General, if we're unable to, if you don't have the information on that, and maybe you can just go have somebody check on that.
Yeah, I definitely don't have info on that, but can I just kind of in order what Senator Fabella just threw out?
Okay.
Okay, so the first one is enforcement. If any of the HPD or anyone else is not complying with what the current policies are, like if you claim that surfers are getting ticketed, I need the exact names, and a copy of the citation would help too, and I can forward that to HPD. I've done that in the past, and we're able to kind of debunk the claims. So if you just throw out stuff like, oh, these guys doing this, it doesn't help because HPD cannot do anything. So I need some help to give more specific information. So that's what one for. The other one is we got to be careful. We're not targeting locals. We're not targeting just the tourists, right? By law they cannot do that. So I would say if they think we're only targeting the locals, that's not a fact for sure. And then again, I acknowledge everything. I acknowledge the passion. I will talk to the governor and tell him how passionate the Senate is about sending the letter. He does not have the authority. We're not lying. We're not hiding anything. He does not. We're told specifically we don't have the authority from preventing passengers to fly into the state.
No, but he's still.
And then the Pearl Harbor for that. I'm pretty sure if it did happen, that is the military, right? On their property, they take certain actions in preparation for their forces, right? Because they want to be able to limit the spread also on the bases and throughout the service members. So they're taking drastic steps as well. And they're the first ones, right? Came up with a no travel from big DOD down to the different service components. So.
Yeah, I'm going to put something in an email, and everything that I had asked you just now, because you're getting a little bit confused. So I'll put everything in an email, and I'll email it to you, so you know exactly what I'm talking about. These facilities was not made for the military. It was in preparation of a crisis that would be able to utilize these barracks for everyone, not just the military. And it was promised that they would be renovating this thing and be able to provide 3 meals a day at this facility if we come into a crisis. So,
Okay, yeah, send me that. I'll shoot it up. I don't know anything about that.
yeah.
But I think if that was a true statement, we would have used that for the quarantine side right off the bat, if that was really true.
Okay.
Okay, thank you.
Remember in the beginning, right, we used the Navy, the temporary lodging, we did the isolation when we first did the travel ban from China.
Okay.
I would think if that was available, they would have used it, but I'll follow up.
Okay.
Major General, really quick, remember when we spoke about the 14-day quarantine for travelers, and that if they didn't have lodging for 14 days, that we were going to tell them to turn around and send them back? But the last time we spoke, you're saying we're allowing them, if they even have 7 days, then they're back to the, why can't we go back to that? If a traveler comes in and they don't have 14-day lodgings, if we're not able to stop them, then they shouldn't be allowed to leave the airport.
Yeah, so what we implemented across the airport is they get 3 options. So if someone shows up and they cannot prove they have lodging, then the return ticket, right? If, let's say they have lodging for 5 days, and then the return ticket should be on the 5th or 6th day. If they cannot prove that, they get 3 options. We'll wait. You make a reservation. We'll confirm it with the hotel that you got the reservation, and off you go. The second one is get on the plane, go back, and the third option is if you don't, you'll get arrested. And Oahu's been doing it. Kauai's been doing it. I think Maui's been doing it. So we are sending them back.
I understand, Major General. What I'm saying is that they should have a reservation for 14 days and a ticket, because they're supposed to be quarantined for 14 days. They shouldn't be taking a bus back to the airport in 5. And if we do,
how am I going to enforce that, though? We got to be realistic on what my authorities are. How am I going to do? How do I operationalize that?
Well, you already said that if they don't have a place for 5 days or a ticket going back, that you folks are turning them around. So why can't you extend that? If they don't have a place for 14 days, why can't you make them turn around and go back? Same thing. You're only doing several days difference.
With the current policy, I disagree with that. But okay, noted.
Right, because if it's 14 days, they have a ticket 14 days later, meaning they're going to stay in the hotel for 14 days. Now you're saying that if they have one for 5 days, it's okay.
So if they refuse to make a reservation, you want me to arrest them or fine them?
Well, what are you doing now if they don't have a place to stay, if they're only here 5 days? What are you doing now?
So what we're using is the supplemental order. I believe it was the second supplemental that has the self-quarantine order, right? And if in violation of that, that is the legal authority. So if they have a reservation, they're not in violation of the self-quarantine order.
But the self-quarantine is 14 days. So shouldn't the order be for 14 days? Shouldn't the reservation have to be for 14 days?
No, but it sounds like the governor has to change the supplemental proclamation and to allow the Major General that authority.
Well, that's what we're saying. They should be pursuing that. If we can't stop non-essential travel, we're trying to do as much as we can to deter people from coming here. And if you can turn them around and put them back on the plane because they don't have a hotel reservation or they don't want to do something, then why can't we do it if they don't have a 14-day?
General Hara, can you explain to me how people who are going to non-hotels like vacation rentals or saying they're visiting family, how do you check those out?
Yeah, to be honest, I don't know. I think that's a gap right now. So the short-term rentals, though, are banned, right, in the supplemental as well. So if they cannot prove that they're at a hotel or not the short-term, then those are the ones we're seeking out. But I'm not calling every family to verify that that's where they stay. We're not doing that.
So is there a number that people can call? I have one in my neighborhood, a 5-minute walk from where I live, and I have noticed I think 2 different families. It's I think an illegal Airbnb, and I can see that they have been to the beach. They have boogie boards that they're washing out in the yard. Several children, and we know it can be an illegal B&B. Is there a number that people can call to report it so that HPD or somebody can go and check?
I'll get you that. I don't know. I think it would be a combination DCCA for the violating the short term, and then the HPD to, once we confirm, send HPD out there. But I'll work both and try to get a number.
Thank you. My final question, what's the status on trying to stop RIMPAC?
So we're not trying to stop RIMPAC. Governor, I think you guys saw, I don't know if you saw the information came out from both Indo-PACOM and Governor Ige. They had a conversation yesterday. Basically, they're looking at how they can still do the exercise without risking anything to the Hawaiians. They have several courses of action. They haven't decided on one, but I can tell you from without releasing what my agreement with Indo-PACOM is. I am confident that whatever they decide on will be totally safe, and everyone will be satisfied with their decision.
Okay, take your word on that.
Okay, well, maybe when you present the plan that you talked about, the response plan, hopefully at that point you have some information that you could publicly share.
Yeah, correct. And I can do it offline too, right? Because again, they're the release authority, so I don't want to get in front of Indo-PACOM and lose that trust.
I just wanted to follow up on something Senator Kim brought up. It sounds like you need a lot of resources to help tracking, calling, monitoring people.
If you had more help.
Yes, I know Rona Suzuki was working on first a computer web-based system, and then later they're going to convert it to an app. I thought it was going to roll out on Monday. I don't know the status on that. I think I told you guys last, I haven't even seen the capabilities yet, but it's supposed to be able to track individuals, and it's supposed to be able to check in I think it was like 3 times a day or something. I forgot what it was.
Okay, in the meantime, the Department of Human Resources gave us a list of 706 people that are non-essential and unable to do teleworking. And so I'm hoping that DHERD might be able to deploy a good portion of these 706 people to help to do some of the things that you're talking about.
Follow up on calling where they're staying at.
They could do more.
Yeah, I think the first priority was to DLIR. Second priority is to Ha'ima, trying to get the response team going, and then after that we can look at helping with enforcement. Okay, well, doing the follow tracking and stuff.
According to DLIR, they need about 50 more people, right? There's 706 people on this list, and they include librarians, attorneys, office assistants, electricians, investigators. I mean, there's all kinds of people on this list that I think probably are qualified to help both either labor or you guys. So I'm not sure if there's any conversation between DHERD and Ha'ima.
Yeah, we've been in coordination, and my deputy is the one that's dealing daily with them on this very issue.
Okay, so the app is not gonna is gonna get deployed at some later time.
Correct. Probably today or tomorrow.
And that's supposed to be for visitors. Incoming visitors.
I got to work with I'm not sure how they organize, but I know they're making the calls now, and I want to see how we can augment without stepping over what they're supporting us with.
Okay, and I just wanted to clarify one last thing. I think what the committee is asking for is not so much that the governor, he himself may have the authority to shut the airport down, but he definitely has the authority to send a letter. And then we can deal with the consequences at that point by strengthening the proclamation.
Correct. Yeah, so like I said, I'll have that discussion with him today.
Okay, thank you.
Can I clarify? I don't think we're talking about shutting the airport down as stopping non-essential travel. I mean, we still need the airport open for residents returning home, inter-island,
medical workers,
medical and cargo. So it's really stopping all the non-essential visitor travel, etc.
Right, I acknowledge that.
Just one more question on the airports, or some follow-up. We've heard that some crew from the planes are coming in and staying overnight and testing positive. So if you work with the airports or the airlines, can you please check on that, that when they come in, that they don't come in and stay overnight as well, that they return home on the flight that they come in?
Do we have specific information who the people are, or
I could get that.
or what air? Yeah.
Okay. And likewise with RIMPAC, if they come in, that the testing would, I mean the testing, that, yeah, whatever their exercise is, that they stay on the ships and not come into the you know, the population, if that could be addressed as well.
No, see, I didn't know they were testing. I thought they were only doing that.
Are they testing airline crew?
Well, actually, they're not testing anybody at the airport, right? They're just doing the temperature checks.
Correct.
Yeah, are they temperature checking the airline?
Yeah, and then the flight.
And I'm pretty sure the airline's not allowing COVID positive crew members to get on the airplane. That'll be. I'll look into it if you can give me details, but I highly doubt
I'll
it.
check on that, General.
Okay, but
Okay.
and then real quick, I know you gotta go, but the last question is: does the crew get temperature checked?
Yes.
Yeah. Okay. Okay. Thank you. And then we'll coordinate with you for sometime early next week.
Hey, Senator, can I call you now on some of the offline stuff after we hang up?
Yeah. Okay. Thank you.
Okay, Chief. Thanks.
Okay. Sorry, Director Anderson. You said you had to wait. Yeah.
I'm going to the same place in O'Hara.
I know. So he only needs about 10 minutes.
Yeah. You got about 20 minutes.
Okay.
Thank you for chance to answer questions. I thought we haven't announced it yet today anywhere else, but we had 25 new reports today, new cases. And by the way, you've heard about the 15 on Maui.
Yeah. Yes.
Those are old cases. They actually counted those already, so we don't have 15 more cases. What they found at Maui Memorial is that there's at least one cluster of individuals who we've now been able to tie to the facility, and of course they're being all the cases are already in isolation, and the contacts are quarantined at this point. Those that we've had, the outbreak, if you will, started mid-May last month. March, excuse me, mid-March, and so they've happened periodically over that month. But now we've been able to tie them all back to workers at the facility who were transmitting the disease to other co-workers, and actually one of the problems that was noted is that Maui Memorial is not adhering to the infection control principles that most of the hospitals around the state are, where they require masks for people who come to the building. You know, I don't know if you've been to Queens or something, but they'll do temperature checks. In fact, many hospitals, they don't even allow visitors anymore. But Maui was not doing that. Further, we all say there's plenty of PPE around. Well, that wasn't the case. I've had contact with a number of people in the hospital who said that PPE is essentially being rationed as it is, and that they're having trouble getting masks and other protective equipment on occasion, probably because they're saving it for future use. But
is this only for Maui or for all the hospitals?
No, I'm talking about Maui Memorial.
Okay.
Most of the hospitals here are doing a terrific job in assuring that their health workers are protected, and that the visitors and others are doing temperature checks on them, and of course if a patient comes in who has respiratory problems, they immediately put a mask on them. So that's the standard of practice, and there are other things they do too, but those are some of the basics. So I think there are lots of things contributing to that situation on Maui, but one thing you need to know is we are aggressively pursuing all the contacts of those cases. We are testing all the close contacts of those cases, and we're continuing to do that. This just came to our attention yesterday, and that there was a cluster, apparently at least one cluster of cases. It's not the entire hospital either. It's as I understand it, one of the wings or sections of the hospital that seems to be affected. So the hospital's still operating. There's no danger at this point of ceasing services, but obviously there's a problem, and they're now in the process of identifying any staff at the hospital that may have symptoms. They shouldn't be working anyway, but given the situation, they're pursuing that. So I just want to give you an update on that situation, because you're going to hear about it on the news tonight. One other item there, the cruise ship that's in port here has 6 individuals who are symptomatic, and I think all have been found to be positive for COVID-19. These are crew members. Those crew members are being isolated on the ship. They're not being allowed to go. The crew members who are well are being allowed to go directly to the airport and back to their home states. And as far as I know, that's where that is right now. I think that I just thought I'd share with you some of the updates on that situation.
So the 6 passengers that are sick, do they fly back?
They're crew members.
Oh, they're crew members.
They're all still on the boat, and they're isolated there.
What about passengers? Is there
No passengers on the boat. The boat was just coming through Hawaii. At least at this point, there are no passengers, just the crew members. They kept the skeleton crew there, I think, for various reasons. But again, the individuals who are well, they're allowing to go directly to the airport, directly back home, presumably with temperature checks and make sure that they really are well. But I think those are the updates I wanted to share with you. So we've had, you look at the curve here, and over the last week or two, we've had between 10 and I think the high was 34 cases per day. So it's bouncing around. We're not seeing that rapid peak that we've anticipated, as many places are seeing that yet. I'm not saying we're through the woods here, but so far we've seen what we'd expect in terms of number of deaths for each case. We have a total of 6 now. I don't know if this is being televised or not. If it is, I'm sure it'll be announced in a short time. We had one other case on Maui, a death reported where an individual had it was an unattended death, and the coroner did test the person for COVID-19 and found the individual was positive. The coroner's report was, I think, dated on the 2nd of this month. We don't know when the time of death was. We haven't had a chance to look at it. And that heard about that just before I came over here. But it wasn't, none of the 2 deaths were associated with that cluster of cases at the hospital. No ties to those, so you need to know that. Anyway, that might be helpful just by way of a quick update. I want to say one more thing, because I think it's on the back of your minds if you're not asking it. That is on the testing. In the paper there was a headline today about the fact that we should do more testing. We are testing all the close contacts of every case. We've done more testing in Hawaii than most other states have done in the United States. In fact, we've done more testing than they've done in South Korea on a per capita basis. We're on par with the other 2 countries people keep pointing at, Singapore and Hong Kong, which we have 10,000 or so tests per million people. They have about 11 in Hong Kong and 12 in Singapore, I believe. But we do twice the testing that they did in South Korea. So when you say we're not doing a lot of testing, it's not true, first of all. And secondly, I think the only states we were one time actually higher ranked. New York had done more testing per capita, and look where they are. Louisiana had more testing than we did. We were 3rd for a while last week, and I think other states have come in, but we're still doing twice as much testing here as most states are in the United States. So I just want to share with you that we're not testing people. Testing is not a panacea to this problem. We have to get a surveillance system in place to know what's happening now, and we're going to need that later when we get this disease under control and start managing it. One thing we're going to, I'm sure, talk about a lot over the next week or 2 is the projections on what's going to happen, and whether it's a month or 6 months or a year from now. There's a point where we're going to see a drop in the number of cases, and over a couple of incubation periods, there, we would determine, at least with our controls that we have now, we might be able to lift some of those. And we're going to have to do this very judiciously. But obviously, we're going to get to that point at some point. And we're going to have to manage the situation. It's not going to go away. It's like the flu. It hangs around. But if we can manage it, we can at least stop some of these draconian measures we're taking now, and hopefully then be able to do what we will be doing in the future, which is basically doing aggressive case identification, contact tracing, and managing the situation as best we can. But it's not going to go away, and I think what the arguments are now is, well, how long is it going to take us to get through this hump? You know, we're all hunkering down now to avoid a peak that's going to overwhelm our healthcare system. That's basically what everyone's doing now. So when we get through that point, and we can feel comfortable that we can manage this situation, then is when we should be looking at, so what do we need in place then to manage it? And we're going to need to have the surveillance systems going. We're going to need to have a really aggressive case identification, case control, case contact follow-up, and probably there'll be some other social changes that will result from this whole thing that we'll be having in place for quite a while. But hopefully we can return to normalcy there, because I don't know how you all feel about it, but what we're doing now is just not sustainable. We can't do this for, maybe through the end of April. Most people think, I can stay home for that long, but no one's going to be in their home for a year or more. It's just not going to happen. So I think we're going to need to think about, what do we need in place to be able to manage this situation in the long run? We have to manage it. It's like the flu. It's not going to go away. We may get a vaccine in a year or whatever it might be, and that'll help a lot. Of course, then we can vaccinate people, and hopefully the vaccine will be effective for a long period of time. But short of that, we're just going to be in a long-term management situation. And again, I think we've got to position ourselves starting now to get to that point. Hopefully it'll be in another month or so when we can basically start doing what we all love to do here, and we can open up businesses and things that we absolutely need to do. But I do think it's important to think about where we want to be then, and realistically, what do we need to have in place then, because we need to start planning for that now.
Question. Director Anderson, can you tell me, you talked about the amount of testing that we are doing. How many tests a day are we doing in Hawaii, and how many of that are local? Or are they in?
I can't tell you how many a day. We've done 15,000 tests here since the outbreak began. When was that, February 2nd or something like that? So 15,000. And we've ramped up considerably since the beginning, when we only had one. Our lab was the only one doing any testing. Now the commercial private labs are doing they're doing all the clinical testing, which is appropriate. They do clinical testing for everything else. We serve as a reference laboratory. But it comes in spurts, but I'd have to get back to you on the exact number of tests per day. We're not able to do them all here. The labs, the two clinical labs in Kaiser who are doing them, are still sending lots of their samples to the mainland simply because there's too many samples coming through for them to process them here.
So of the 15,000, how many are still outstanding that they haven't gotten the results back?
Well, the tests going to the mainland are diminishing. At one point, I called last week. I can tell you last week, 500 were outstanding. That's correct. And it sometimes takes us a week to get the results when we send them to the mainland.
Or 2
The mainland labs are overwhelmed too.
Our own senators had 2 weeks experience. Yeah.
Well, back then, almost everything was going in. At one point, there was a 10-day delay.
Last time you told us we had a 1,500 that we didn't get the results, and I had asked what percentage might come back positive. Do you know what percentage of that came back that was positive, of the 1,500 that was outstanding?
Well, I can't do the math in my head, but if we had 15,000 tests done, and we now have a case count of 400 and, excuse me, I should know this number, 435. you can assume that all the rest of them came back negative. So if you subtract 435 from 15,000 approximately.
No, that's not my question. My question was, we had 1,500 that was outstanding the last time you were here. We had asked, of the 1,500, well, how many of those would you expect would come back positive? And you said you couldn't come up with a percentage. So now it's after the fact. Do you know of the 1,500 that did come back, how many had been positive? Because of the 500, is there some percentage that we can say there might be 1% of that may come back positive?
I follow you. Thank you for clarifying. I don't think the percentage of positives has changed much over the course of the testing we've done, except that when we first started doing it, when we did the testing, we were pretty sure that we had a positive, so the results were very highly skewed.
Josh Green just texted me and said 2.8%. 2.8% we can expect to be positive.
Well, he has probably some numbers I don't have, but that's probably a ballpark figure.
Well, that's kind of what we want, some ballpark figure. He said you go to the same meetings that he goes to? They get the information?
No, I don't.
No? Okay, sorry.
The yield here is, I should say, on the positives versus testing is much lower than it is most states. Most states are not testing unless they're pretty sure that the person has COVID-19. So I looked at some data from another state recently, and a third of the tests are positive that they're doing. It depends on who you sample.
I'd like to follow up on the testing and also the contact tracing and contact testing, because it seems that if you're targeting and you're testing, because this is a public health problem, looking at how the community spread is going, that kind of data should be important for us to know, and how much is it being spread out, and after the quarantine, are they still being tested positive, or are they now negative? So are you keeping track of that kind of data, and can we see some of that kind of data coming out from all of these positive cases?
Well, there are a number of reasons people test. First of all, it's useful for clinical management purposes. So people who are showing COVID-19 symptoms are tested to determine whether they have COVID-19 or the flu. It doesn't matter too much on how they're treated, but it's helpful, particularly if they're very ill, to know whether it's COVID-19. So that's one kind of test we do. There's a lot of testing being done right now. Some of it's very focused on outbreaks. Some of it is this drive-through testing that you've seen. That's very, the yields on that is very low, as you might expect. You get a lot of worried will coming to those drive-ins. The most valuable testing that we do from a public health standpoint is the sentinel surveillance, where we randomly test people who have flu-like symptoms in the community, and we test those people, and then we can determine whether or not we're missing people. And of course, we do have the case reports, so we know what's happening, from that. So there's a variety of different tests being done for different purposes, and they all tell us something different.
So how is that analysis being used in terms of actually how we project?
Okay, well, I'll give you an example. I mentioned the surveillance we're doing, which I think needs to be expanded dramatically. Right now, we've, I think, tested something in the order of 300 to 400 individuals in this surveillance program. We found 2 people to be positive. What that tells me is that there is virus circulating in our community, but it's not widespread. These are tests being done on all the islands, all the counties, including Lanai and Molokai, and that gives us a sort of a pulse on what's happening out there. These are random tests, so there's no reason to think that the one area is more cases than another area, and diseases would pick it up. I think that needs to be expanded, and we need to continue that, because that gives us a pulse on what's happening, and we should do that regularly and continue to do that. That's the best testing we have. And that tells me at least that the testing is being done. That tells me that there is some community spread, but it's probably localized, and we're not seeing a situation, obviously, like we're seeing in New York or some of these other places where there's obviously a whole bunch of disease going on.
But what about the COVID positive cases that actually have COVID infection. So I know when Dr. Park and you were here, I don't know, several weeks back, you said it was difficult and you needed a lot of staffing to actually do that contact tracing. Is that still a problem, or can you do that with anybody who's positive? Everybody they touched can then be tested or tracked so that we can keep track, because that's where the spread would come from.
Good point, and a good question. So we follow up on every positive case we get. We find out who the person was, what their travel history was, where they've been, and we try to identify as best we can close contacts for that individual. And we do follow up with all those close contacts. Some, were sick, went home and didn't go anywhere. They knew they were sick and they stayed home. Hey, maybe their wife might be a contact or husband, whatever the case may be. Others, unfortunately, went to work or had lots of people who they may have spread the disease to. And then we have sometimes 100 contacts or more. We have to contact every one of those people and find out what their history was. And of course, we will test those, whether they're symptomatic or not. We've actually begun testing asymptomatic close contacts to be sure that they're not eventually going to be spreading the disease. So that's a tedious procedure. I can say we're keeping up reasonably well with that, with the low number of cases we have. Again, 30 today. We've got a bunch of staff working on this on all our islands. So we can follow up pretty well on most of those. If we get up to what other states are experiencing now with hundreds, that's not going to be possible with the staff we've got. We have medical students, we have nurses and others in the wings, and we actually have recruited some of them to help us in some of these situations. So I think we've got a pool of people. General Hara has identified some National Guardsmen who can help us if we need it to do the contact tracing. But that's an important part of, that's mostly what public health does. We find cases and we try to identify how they got infected, and we, of course, isolate or quarantine the people who may be a problem.
A couple of follow-up questions. So in the quarantine, do you tell them that we want to keep you 14 days in quarantine, and you aren't supposed to go out to talk to 100 people in the community?
No, I'm not sure he has the contact with those people, though.
Well, the visitors are one thing. I heard Director Hara refer to what they're doing with the visitors and others coming to Hawaii. Well, it's not just visitors. Returning residents have to go through 14-day quarantine. And I think there are attempts to follow up if they go to a hotel.
But these are the positive cases.
Positive cases we check in on and we monitor much more aggressively than we do the visitors. Keep in mind the numbers are much smaller.
Testing too.
And the testing's done, again, for of course all the cases. We've got that test done. That's how we identify it's a case. It's a COVID positive.
After the 14 days.
No, and as far as releasing someone from quarantine or isolation, the CDC policy is the one we use where, if I could be wrong on this, but it's 7 days after the symptoms have been resolved, at least 7 days, and it depends, of course, on the circumstances, but generally that's the rule. Some countries were actually requiring 2 tests to be done, both negative after someone came out of the hospital. No one's doing that anymore. It's just too time-consuming. So they look at a time period, and I think our time period, the current one, the recommended by CDC, is 7 days after your fever's gone and you're healthy, or at least you're not sneezing and coughing. That's what they think is appropriate, and then they can be released from quarantine.
I think with that.
Okay, we gotta move on, Chairman.
Critical, but I just wanted to mention that if you could talk to Riker, if you do need additional staff to continue the work that you're doing, and if you're short-staffed, he does, if you can relay that to him, so that you can the appropriate number of staff to help you.
By the way, we are moving some health department staff from a situation where they're not able to do their function to helping with some of these activities. So even within the department, we have 3,000 people in our department. So we do have some reserve there, and we do have public health nurses and others who are helping us now in the disease control activities. But even with that, we probably are going to need more people. So maybe someone in DHS or someone can help us too.
Are you making use of the DOE nurses, health nurses?
I think, I'm not sure what, we haven't so far as I know, but
Wait, Jared has a question.
I might.
Okay, Senator Keohokalole.
Thank you, Chair. Thank you, Director, for being here. And I do want to thank you, since we last spoke about releasing the data, because it's been a lot better, and I've had a lot of dialogue with people who are calling for that, and so you do deserve from me to be commended for the comprehensiveness of the data that you've been putting out. There's still more that people in the community would like, but thank you for that. The question I have is around sentinel surveillance. Thank you for not calling it community surveillance anymore, because that didn't sound right to begin with. But my understanding is that the World Health Organization recommends the sentinel surveillance technique for dense communities. And you just said that you had more capability and resources. That's where you would invest them, not in more aggressive testing. And well, I think I'm understanding your contact tracing justification and answer. Can you talk a little more about why sentinel surveillance, if you have more of the limited resources you have to deploy, why you would invest it in that?
Sure. Thank you for the question, and I appreciate your acknowledgement of publishing the epidemic curves and age distributions and other things. We want you to know what we know. We're not keeping secrets, and although we use it, it's important other people have it too. But the sentinel surveillance program, the thing that's valuable about that is, first of all, it's looking at people who are ill. First of all, so you're eliminating a lot of people who are not ill when you're doing your surveillance, not wasting your efforts. I would look at it as a targeted surveillance program with a random selection of people who are ill. And what happens is they actually are tested now for flu and for COVID-19. So we have actually a good pulse on who has the flu as well as who has COVID-19. But the beauty of it is that because it's a random selection process that we don't miss things. It's, we want to be sure that we're checking broadly around the community, and what I worry about to some extent is their sampling isn't as thorough as it might be randomly. So we may be missing pockets of illness that might be occurring just simply. It just has they fall through the cracks and we just don't see them. For example, I'm not sure we would have seen that outbreak at Maui Memorial. I mean, it's a relatively small number of people, 15 people out of a state of 1.4 million, and it's very possible we wouldn't have seen any illness if we just counted on our current random survey. But the value of that is it is broad-based. It covers all the areas of the state, and it focuses on people who are ill, which is really the target you want to focus on. You could do a random survey of people who aren't ill, and you'd get lots and lots of negatives. But at least this picks up the people who are ill and gives you a better pulse on that. And by the way, the test we use is really only targeted toward people who are ill, who are actively shedding the virus. So one of the problems with this test that we use now is if you are pre-symptomatic, it's not clear that the test would pick you up. And you could still have the virus, but the test may not be positive. So the nice thing about the random survey of people who are ill is that we know that if it's COVID-19, we're going to know that they have it. So it's the best.
So Director, let me clarify, because we've been over this ground before. I understand what you're trying to accomplish with the sentinel surveillance. Earlier, we had the Lieutenant Governor on, who has called for more aggressive testing and contact tracing. And what Chair Dela Cruz mentioned to him is, where is the source reference that advocates for that policy directive at this point in the outbreak? Where is the example from other jurisdictions, countries, communities that says, this is where we at in the outbreak, this is what we should do when we get more resources? And so can you point either the CDC or the World Health Organization. I'm just making assumptions based off of my own research. What can you cite to indicate that we should go sentinel surveillance, and what conditions would allow, from an epidemiological standpoint or a logistical standpoint, manpower, resources, the more aggressive testing posture and contact tracing that the Lieutenant Governor is alluding to?
Let me say one thing, that many states, including, in fact, most of the states in the United States, have just given up entirely on contact tracing. There's so many cases occurring that they've just said, we can't do it anymore, and they're focusing on social interventions, basically the stuff we're doing. Stay home, keep yourself distancing from other people. They've long since stopped doing what we're doing here. So we're doing that, and we have, of course, I think some of the most stringent restrictions on activities of any state. So I think between the two, we're in a much better position than most states are. It doesn't make sense to go out there and just test people. The test itself doesn't do anything. First of all, it's in terms of changing the course of what might happen. Again, New York State has more tests per capita than anywhere else, and they also have the most deaths, and they're in the most dire straits right now. It helps you get some pulse on what's happening to the disease, but when it comes down to a very practical stance, testing doesn't stop the spread of the disease. It's only effective if you have adequate contact follow-up. So Lieutenant Governor's probably right. If you're doing testing, you've got to have that contact follow-up. Otherwise, it's just a total waste of time. And it certainly doesn't change the course in terms of how a person's treated. If a person has COVID-19, there's no treatment for it. They're basically treated the same way as if they had another respiratory illness, except in some cases when they get into the ICU and they need ventilation. The COVID-19 patients typically need ventilation more often, so a decision to ventilate them might be made quicker if they knew they were positive. But you've got to have the contact tracing in place, or the testing's just a complete waste of time. It gives people often a false sense of assurance they're not exposing anyone, which may not be the case.
Okay. So we're treading over the same ground again, and that might be my fault. This will be my last follow-up. From a logistical standpoint, because that seems like your medical justification for the course of action. From a logistical standpoint, how many more people would you need in the Department of Health to do contact tracing if we just started deploying a more aggressive posture? I know that's a difficult one to ask, but I mean to answer, but just if you could just take a shot at it. Okay. And then how much are these tests going to cost us in the long run, and is that a consideration? Thank you.
Yeah. First, with regard to I think it all depends on how many cases we end up having to track. Obviously, that's going to determine how many contacts they have and so forth. I've suggested to Sarah she look to triple her staff to be able to handle what I anticipate we're going to see in the next few months. And I think that should be sufficient given what I at a minimum at least, and it could be more, but that's the order of magnitude of increase in staffing.
So how many people is that?
I hesitate to come up with a number because she has staff not only here on Oahu but on the neighbor islands, and now she's using staff that have been reassigned in many cases to help. I'm going to say I think she's got roughly 20 staff here who are doing that right now, and that would get us to about 60 or so. And again, that's just in the short term. I wouldn't be surprised if we're going to need a good 100 people dedicated just to doing this. And that's not just now. If we want to keep this thing tamped down, we're going to need that many people going forward, and probably for the foreseeable future. I'm talking for the next years, to keep this thing down under control and do it adequately. I really have to run. I would love to come back and answer questions.
But I think your last point though was really important for the committee to know that that's where we're headed. I don't think anyone's disagreeing with that, and whatever we can do to kind of help get that up and running. So, but thank you.
Can you do cost also, please?
I can get back to your committee.
Okay.
I think someone's asked us your committee with that, and I'll try to get a number to you on what it would cost to have a staff of 100 doing this.
Dr. Anderson, can I just leave you with, we talked about testing and we're only doing 1,500 a day. I just wanted to ask if you knew that the UH JABSOM, their lab has been CLIA certified, and are we bringing them on board to help test?
Yeah. Well, CLIA certification is required. I don't know that they have the equipment or the expertise to do the PCR test, which is what we do. We'd welcome their involvement, and if they could be certified, that would be terrific. We got 2 commercial labs, three actually include Kaiser, and of course our district health office right now, not district, our own laboratory, and that's it. And we'd
Correct,
welcome.
but 1,500 a day is only 1/10% of our population, so I still have concerns that we're not being
Again, keep in mind that even the states that are in the countries that are doing this, we're doing better than they are on a per capita basis, and they're sampling less than 1% of their population. You forget what, in a country like South Korea, it's huge. So you run into a numbers game, but we're never probably going to be in a situation where we're testing everyone, and probably even if we were testing 5% of the population, we'd be doing really, really well. But that gives us a good pulse on what's happening, and it also would allow us to follow up on cases.
So who can we follow up to see what certifications UH would need?
Oh, our laboratory director, Dr. Desmond, would be.
We just follow up with that.
Right.
Okay. Can I just request that you guys be more proactive like that to check into JABSOM before we ask the question, and also that you agree that adequate contact follow-up is needed. Why didn't we start that from the beginning? Why didn't we want to get more staff from the beginning? And you're not even sure how many staff we need. Those are the kinds of things we're asking you guys to be proactive on, and don't let us be the ones to tell you, but let's move it. Let's move fast.
I think we know a lot better now than we did a few weeks ago where we're going with this. So I'll get back to you with the numbers.
Okay. The number of people and the cost, yeah.
Will do.
Okay, thank you.
Thank you.
Okay, so we'll adjourn, and then members, if you can take a look at the draft agenda for tomorrow.